back, guys. For the sake of time, we might start the next session. So the next session will be about breast surgery and breast reconstruction. So we'll start with Dr. Elizabeth Lazarus. She is a graduate from the University of Cape Town, South Africa, and is a fellow of the Royal Australasian and New Zealand College of Radiology. She is a senior staff specialist at Liverpool Hospital and is actively involved in GP education and breast imaging. Welcome to the stage with me, Dr. Elizabeth Lazarus.
Hello everybody. I've been asked to speak about screening for breast cancer, just the various options that are available at this time. So just to give you a few statistics, as you know, the risk of breast cancer increases with age. About 24% of new breast cancers in women diagnosed in 2007 were in patients younger than 50 years. The average age of first diagnosis in women in 2007 was 60 years. But also good to know that a woman's risk of dying from breast cancer has been declining. And very important, in 2006, the 5-year survival for tumors 0 to 10 millimeters was 98.2%. And that is the whole point of screening, to get the cancers early on. So when we say screening, what do we actually mean? A screening mammogram is a standard 4-view study performed on completely asymptomatic women in an attempt to diagnose breast cancer at a preclinical stage. So, as you know, in Australia, free screening mammos are offered for women between the ages of 50 and 64 years, and that's because this target age group has the highest rate of breast cancer, and this is therefore the most cost-effective population to screen. But internationally, they do say that breast screening should start at age 40 years and should extend past 64 years. It's less cost-effective, but the Swedish results show significant reduction in death rates of about 40%. They say that women over 50 years with no high risk factors, that's just normal risk women, screening is advised every 2 years for the rest of their life or until other medical conditions supervene that make the diagnosis of breast cancer irrelevant. HRT policy is to screen annually after 5 years of HRT use. So for women less than 40 years, what's advised is annual screening if a patient has a high-risk family history, which is first-degree relatives diagnosed with premenopausal breast cancer. And they say that screening should start 5 to 10 years earlier than the age of the youngest relative at the time of diagnosis. Screening mammography is 90% accurate. What is good about breast screen is that the risk is minimized by double reading of the mammograms, and this is really the only technique shown to decrease the death rate from breast cancer. It does detect DCIS, and it's still unclear which DCIS will progress to invasive carcinoma, and we may actually be over-treating DCIS. But at present, we do treat it as a malignancy, and with adequate treatment, there's 100% 5-year survival. So now I just want to touch on a subject which is in the news very much, especially in America, and that's breast density and risk assessment. So when we talk about breast density, breasts are mainly made up of fatty and fibroglandular tissue. As you know, the fatty tissue is dark on a mammogram, fibroglandular tissue is white. So the amount of white that is visible on the mammogram is the breast density. So if a patient has more fibroglandular density, a tissue compared to fat, the whiter the mammogram will be and the breast will be classified as more dense. Just remember that breast density cannot be determined by the way the breast feels or looks. It can only be determined by the mammographic appearance. So I often get patients coming, my GP says I've got very dense breasts, and then I look and they are completely fatty. So on mammogram there are 4 categories: less than 25%, 25 to 50%, 50 to 75%, and greater than 75%. So we consider greater than 50% dense breasts. The BI-RADS categories are A, B, C, D is what we use, and C and D are considered dense. A is almost entirely fatty, B is scattered areas of fibroglandular density, C is heterogeneously dense, which may obscure small masses, and D is extremely dense, which lowers the sensitivity of mammography. So this is a category A breast. You can see lots of fatty tissue, easy to interpret on mammography. This is category B, where there's more white, more dense fibroglandular tissue. This is category C, and this is category D. And sometimes you can actually get completely white breasts, which definitely do have a higher risk of cancer. So there's a new technique called, it's called Volpara, and quite a few other vendors have a different technique. And this actually categorizes exactly the percentage of density in the breasts. And so what it does, it's the same categories A, B, C, and D, but it tells you the exact amount of dense tissue within a breast. And breast density is emerging as one of the strongest independent risk factors for breast cancer. If you're in the highest category of breast density for age, women are at 4 to 6 times increased risk of breast cancer compared with women at the lowest category. So, women with dense breasts are not only at increased risk of developing breast cancer, but are also more likely to mask breast cancer, and that may result in delayed detection on mammogram. As I said, these are the risks. If you're category D, you've got 2.14 times increased risk, according to Cancer Australia, and these were the figures in 2018. So this was this new Volpara density. It's automated. And why I think it's so good is that there is inter-reader and intra-reader disagreement when we categorize the breasts. So now what happens is the Volpara, this patient has got a breast density B, and it actually takes the amount of fibroglandular tissue in each breast, takes the whole volume of the breast, divides it, gets a number. Over here, 6.7 was the number that was the highest, and it puts it on a scale. I don't know how to indicate, but anyway, this patient has breast density B, which is high B, which is relatively low risk. And just in terms of breast cancer risk factors, this is where breast density is. Obviously, a family history gives a high risk. A prior history of breast cancer, obviously that's a really high risk of redeveloping cancer. So dense breasts mask breast cancer. This was a patient, breast density category D, breast screen cleared her 3 months prior. She's actually got a spiculated mass, difficult to see, and this was the ultrasound which showed an invasive carcinoma. What I am trying to do, and I'm getting there, but I've just got this Volpara density, is eventually I would like to give a patient by patient risk assessment so that every single patient has an individualized risk for the development of breast cancer. I want to implement risk-based screening. At the moment, in Western Australia, they have breast density on every single mammogram. I think they've just done it at Breast Screen Victoria as well. New South Wales is a little bit slow to catch up. But what I think they're going to do is, in every patient, they'll say, this is the breast density, we recommend you see your doctor. And when they go to the GP says, your breasts are dense, you need to go for an ultrasound. It's very different in private, where we basically do ultrasounds on all patients, but I am talking about breast screening. And this automated breast density is now incorporated into the clinical screening workflow as it provides reliable risk stratification. This is the risk evaluator. Eventually the patient's going to walk into the practice, type everything on an iPad, say exactly, when they had menarche, if they've got a family history. We'll do the breast density, and it will spit out the risk, which I just think is a lot more accurate than us guessing. And as I say, it stratifies patients. So a patient of average risk, which is less than 12.5% lifetime risk, we recommend screening mammograms every 2 years. If the breasts are dense, category D, we say do a 3D mammogram and ultrasound, which now I think is routine in most private practices. If a patient is moderately increased risk, might refer it to a familial cancer center. They say you should screen from age 40 to 49 years every year, and then every 2 years from age 50 to 74 years. Once again, if they're dense, breast density category D, think about a breast MR or contrast-enhanced mammogram. Also, consider starting earlier if the youngest relative is diagnosed with breast cancer under 40. And then high risk, there are other screening things, but that patient should go to a familial cancer center, which they have at Liverpool Hospital. They have a genetics clinic. They have it at all the major hospitals. So ideally, one day, this is what I would like to be on my radiology report. based on Mrs. X's personal history, family history, and Volpara volumetric breast density, her lifetime risk of breast cancer using the IBIS risk evaluator places her in the average risk category for breast carcinoma. 2 yearly surveillance with mammogram and breast ultrasound is recommended. And I think that just will help you all so much, because at the moment I see a lot of the patients after they've had their mammogram and I struggle. I say, look, your breasts are dense, you haven't got a family history, come back in 2 years, but you must have an ultrasound. I think it's much better if it's automated and we know what to do. And that would be different cases. So just to talk very briefly about a new technique called contrast-enhanced mammography. I'm not going to dwell on it. I don't have it at the Liverpool practice Spectrum. We do have it at our Randwick practice. It's a new technique, and what it is, it's like a CT scan, and you give intravenous contrast while you're doing the mammogram, actually just before you do the mammogram, and then you do the mammogram, and what it does is highlight if it's breast cancer. It enhances, because it's all about the tumor angiogenesis and forming new blood vessels. And it's actually very similar to MRI in terms of its pickup, and I think it's a great technique. It's taken on in Western Australia, and quite a few private practices now have it. We take the mammogram with iodine, we then subtract it, and what's left is the breast cancer. So I'm just going to literally show you a few cases. One of the indications, if the patient can't have an MRI, if they're claustrophobic, if they're obese. Also, it's much more accessible. We've all got injectors in our practice. We just give them iodine, and it takes the same amount of time. The dose is probably slightly less than twice a mammogram, and it's still well within the range of acceptable for mammograms. Just want to show you a contrast-enhanced mammogram. So this is the dense breast, and that arrow is pointing to the tiny enhancing cancer, which there is no ways we would have seen without this contrast-enhanced mammography. We would definitely have picked this up on MRI, but if we had good sonographers, we would be able to pick it up on ultrasound, but it is obviously operator dependent. This was another case. We do the normal 3D tomosynthesis. We give iodine. There's something there we're not sure. I think that could easily have been passed by breast screen. And look at that. That patient has got multifocal carcinoma. We just subtract away all the dense tissue, and that's what we're left with. And it gives the surgeons a really good idea of the extent of disease. And the surgeons love it because they're used to looking at mammograms, whereas I think with MRI they struggle exactly to work out where the cancer is. So this is where it shows in the left upper outer quadrant, this multifocal cancer, and we can actually measure the exact extent of the cancer. It has the same indications as breast MRI. Lastly, I just want to touch on abbreviated breast MR. So you all know we do breast MR, and at the end of my talk I'll tell you the new indications for breast MR. The latest now is abbreviated breast MR. Just to talk briefly, so mammographic screening obviously results in overdiagnosis of unimportant biologically inert cancers, but prognostically relevant cancers, which drive breast cancer mortality and lead to the high interval cancer rates, are the ones that we're looking for on MRI. Remember, MRI is not limited by breast density, there's no radiation, the positive predictive value is the same as mammography, and preferentially it detects higher grade lesions. Why is it restricted? Cost, time, and the perceived lower positive predictive value. These are just briefly the yields of all the different imaging methods. The best is MRI, mammogram, and ultrasound. What I use, I do a lot of work for the high-risk clinic. They send the patient for the mammogram, then I do an MRI, and judging on what I see on the MRI, I do a targeted ultrasound. That gives the highest yield of cancer. So there's been a new trial out which showed the cancer yield of MR alone, which is significantly higher with just MR, slightly improved with mammogram, no real improvement with ultrasound. And MRI is basically superior for both invasive carcinoma and DCIS. But obviously the problem is availability, time, and expense. What has been developed now is something called abbreviated MR. With new machines, the total scan time is less than 10 minutes, and obviously it reduces the time and the cost of MR. The problem is that when we do a full MR of the breast, we look and see how the lesion enhances, if it's delayed, if it's plateau. We lose all that with the abbreviated MR, but we are looking for early enhancement, and it's very good at that. Just to show you the future, there's going to be ultra-fast dynamic imaging. Look at this, in 35 seconds you can see already that the carcinoma is enhancing. There, this is normal. A few seconds later, there you can see the enhancing mass. So one day, the goal is to expand access to MRI. Women with dense breasts may have a faster, more sensitive and more accurate option to whole breast ultrasound. And maybe abbreviated MR every 2 to 3 years may prove to be a better standalone test than mammography and ultrasound every year. And there's no radiation. There is contrast. We do give intravenous contrast, but even that is changing, because in the future there's going to be ultra-fast MR and something called diffusion-weighted imaging, which we use at the moment for strokes, where there's no contrast, and it will pick up the cancer really quickly in a few seconds, done, next patient. Eventually, low-cost scanners with one-button scanning. I really do believe it is coming. So this is diffusion-weighted image, and there you can see the cancer. So basically, at the moment, in summary, mammography and whole breast ultrasound is the screening standard in women with dense breasts. Risk-based MRI every 1 to 3 years may prove to be an alternative to supplemental breast ultrasound every year. MRI every 2 to 3 years may prove to be a better standalone alternative to mammography and ultrasound every year in low-risk women with dense breasts. And I think that non-contrast MRI will likely become a screening option. Just to end, there are new MR criteria. They are only for specialists, but I think we have already started to be flooded with requests. And this is that, it's the second one, where a patient has a breast lesion. No, it's actually both of them. The first one is the patient has been diagnosed with breast cancer, and a discrepancy exists between the clinical assessment and conventional imaging assessment, and the results of breast MRI may alter planning. And I can tell you, you see DCIS, we biopsy it, and they actually do surgery. It turns out they've got the margins, they're not clear. The surgeon goes back, redoes it. I think MRI will really help, even though MRI does not change mortality. Also, if we're not sure if it is a lesion or not, we're not sure if it's cancer, we can also do an MRI, which may help in our diagnosis. Thank you very much. Just to say that Spectrum has also started interventional radiology, and this is what we do. Just have a read of that. Yes.
Elizabeth, I might have a question, if you don't mind. I think. Thanks for that. That's fascinating. I think we all agree that advances in medicine is due to the advances in really in radiology. Appendectomy is the same procedure 50 years ago and now, but the major advancement is in really in radiology. So when do you think this high sensitive, low invasive screening will be coming?
In a few years' time, I would think.
We're talking 5 years, 10 years?
Yeah, I would think, definitely. We are already doing abbreviated MR, but I can't do it in 10 minutes. In my Randwick practice, where I've got the 3T magnet, we absolutely can. But not in Liverpool yet. We just need an upgraded magnet, but it's fantastic.
I see. I might pass the message to James if you have any questions.
Yes. Yes, but I still say mammograms are very good for calcification. I still believe that. Yes, for microcalcifications. Sometimes it's got to be a certain grade to be picked up by MRI or contrast-enhanced digital mammography. No, not always. We often see it. I mean, that's the whole point of breast screen, is picking up these microcalcifications, which we then biopsy stereotactically. MR will pick up the higher grade DCIS. So, it might not pick up those low-grade ones which aren't enhancing at all and might stay the same for many years. We don't know yet. Yes?
Thank you for that. That was
gentle.
Yeah, no, that was great, because this obviously where the technology is really changing. If you had to punt whether you think MR or contrast-enhanced mammography is going to take over, I mean, you seem to be working on both fronts.
Yes, I think both will be excellent.
Yeah.
And it depends. Obviously, I want to do MR because I've got MR machines and I've got 6 breast radiologists who are very, very competent. We're just learning contrast-enhanced mammography. It is still an injection, but I think it's also going to do very well. I think they're both going to run neck and neck.
Neck and neck.
Yes.
Right. Okay.
Thank you. Yes. Sure.
Is the contrast enhanced mammogram
At the moment, no, and we don't even charge for it. I think we'll probably just charge a consultation. I just want to get the answer. That is so we're not doing it in Liverpool yet, and so far no one has decided exactly what it's used for. I think I'm going to use it to problem solve. So if I see a spiculated mass on a mammogram, we can't see anything on ultrasound. Normally I would biopsy it stereotactically. Now I'll do a contrast-enhanced mammogram on the spot, speak to the patient, ask if they've got anything, and so we're not even charging for it. No, no, no. Okay.
Any other question? No, we might move on.
Yeah. I see it, not very often. Yeah. Yeah. It's not that common. It's rare, but it exists. And easy to diagnose. We do it on ultrasound and biopsy. I spend a lot of my life biopsying gynecomastia, which I know is gynecomastia, because it looks completely different on ultrasound. Pardon? Yes, yes, yes.
For the sake of time, thanks very much. Thank you.